Hey folks, welcome back to another episode of the Change Physician Podcast. This is your host, Dr. Kevin Cuccaro, with my fabulous co-host, Dr. Melissa Cady. And for this episode of the Change Physician Podcast, we decided to bring you into the dark netherworld of anesthesia. What is it that the anesthesiologist does? What happens behind the curtain? What insights do we have? Do we truly know all your deep and dark secrets? Or are we just sitting there checking on our stocks on our phones while everybody else does something important? This and more for this episode. And Dr. Cady, great to see you as always.
Yeah, ditto. This is an exciting little chat because even our own fellow physicians don't always understand the world that we have worked in or currently work in. And I think it'd be good to kind of step into whether it's the training realm or in private practice. I think, first of all, let's just say I don't leave and go have my coffee and hang out outside of the room. I literally had a patient just ask me this past week, like, are you going to be in the room with me? I'm like, yes. There are some not so appropriate practitioners that might leave for a while and come back. That is not how you stay vigilant for the patient's safety. So let me just say right now, if nature calls and I just need to leave for a minute or two, I'll get someone to stand in my place for a moment. But overall, yes, we are there not to just turn on a switch or push one drug. So many people think you just push one drug and you leave and that's it. It's not like you take a pill and you just like have your anesthesia. There's usually a delivery of medicine on a continual basis, either through what you're breathing or through the IV, in order to maintain your general anesthesia, if that's what you're getting, which means you're unconscious. So I just have to start with that because that is like a commonly asked question. But I think it might be interesting to just talk about some of the stresses, maybe from training, if you want to dive in a few of those, Kevin, because that gives you a little bit of a perspective on what you're in charge of, or what you're doing for the patient. Any little story or little tidbits of things that you realize were, my gosh, it's the first time you did anesthesia.
Okay. Yeah. So let me just start out. So I do not do anesthesia in this day and age. So I'm trained anesthesia. I did anesthesia through the military, but then I did 100% pain. Now I'm doing different things. So these are past experiences. I can't believe that the OR probably has changed that much. So I think they're going to still be relevant. Yeah, anesthesia and training. Oh my God. Like, and this is the thing. I had done, I think, 3 anesthesia rotations at least before I went to do my internship. Or my residency. I was certain I knew what I was getting myself into. Just like the person I rotated with the doctor for 2 years. I knew what I was getting into medical school. You do not know until you are doing it.
Yes.
I had done a lot of intubation before. So I probably had 50 something intubations before I even started my residency. So I was very confident then. Holy crap. It was still the most stressful time period of my life, bar none. And it's going to sound super stupid, but for a long time, my biggest stress was the stupid IV, which sounds, again, kind of stupid. It's an IV. It's simple. Well, you try doing that when you're under this time crunch. Like, I don't know. So we had our morning lecture, right? So you go in, you have to set up your room, which was a whole other thing because you're like terrified and we have drugs that can kill people and you run to keep them separate and all this stuff. And then you had to run from there and you had to go to morning lecture, and the morning lecture was a half hour. And then from morning lecture, you had like 5 minutes, like literally 5 minutes to meet someone, overlook the thing, do a brief history and physical, and start an IV and get them ready to get back into the room. That just gives me my heart beating now thinking about it. It's like, and I had done all this intubation stuff, but what I hadn't done is a lot of IVs. So, oh my God, it was always such a freaking nightmare just to get this stupid IV in. And then you go off and you're going in the room and you're putting somebody, I don't know, you're basically putting people in the thresholds of death's door and then maintaining them there. So holy crap, it was so stressful, like so stressful. And literally it was the time crunch because you got everybody breathing down your neck and then the surgeons are all mad. It's like, well, you let your intern close for 10 hours because they need to learn, but then you're going to yell at me being the new anesthesia resident because I'm a minute late getting them into the room. Or anyway, the hypocrisy is a little profound.
Yeah.
But man, super, super, super stressful. And I don't think, again, like you mentioned early on, is people just don't understand what anesthesia does.
Yeah.
The surgeons I don't think they understand what we're doing. But it is your vigilance, which I think is actually part of the American Board of Anesthesiology's model. I know that's what the lighthouse stands for. That's on the seal for anesthesia. It stands for vigilance. And that's what you do. You literally are sitting there watching numbers and recording numbers, and you're just waiting for something to go wrong, right? It's like, and you're hoping something doesn't go wrong. So the description where they say was like 5 minutes of excitement, 95 minutes of pure boredom, punctuated by periods of sheer terror or whatever, is so true.
Yeah. Yeah. I actually tell people, I'm like, so I'm going to I'm helping with the takeoff and the landing and any turbulence in between. And I'm present for all of it.
Yeah. It's so true,
Yeah.
Yeah, but the other thing was, so my program, I want to hear your perspectives on this, because in my program, the first 6 months, and we were not what I would call a malignant program either. Like, my program director was awesome. I think he was a fantastic educator who really took teaching seriously. They were all, I would say not all of them, the vast majority of them had pretty high standards, which was great. So they expected a lot out of you, but really, really diligent and really, really involved with resident education. And so they told us pretty early on, they're like, hey, this is going to be a stressful time for you. If you are feeling like you're going to quit, that's completely normal, which was huge. Someone actually verbalizing what you're feeling is so huge.
Yeah.
And they said, what I'm going to ask you to do, Dr. Klafta, if you're listening, said, I'm going to ask you to make it through the first 6 months. And then if you're still thinking or feeling this, then we'll have a longer discussion on that.
Yeah.
So it was really getting through that 6 month period. But what they did by doing that is, one, they defined what I was feeling and recognizing I didn't feel alone. Two, I knew my other residents, even if they weren't necessarily expressing or not, were probably in similar throes, or at least they had beforehand. So this was not a unique situation. Three, they gave me a time frame, 6 months. That's all I had to do. And it's amazing when you have an end point for anything, how that changes the game. And we've talked about that for other episodes for a lot of different things. But I knew if I made it through 6 months. What I thought was interesting, though, is once you hit 6 months, then we got to what I call is like the CA1 or first year resident kind of blind optimism, right? Because you've done it for 6 months, then you kind of think you know everything.
Yeah.
And that, I think, is probably more dangerous than when you start, and I can talk about that more in lessons learned, but I'm kind of curious. So what was your impression when you first started? Like, what was that like?
I think I was used to pushing myself and being stressed, that I normalized it. And then I did acquire that sense of like confidence that I could handle anything and be, a little bit kind of like that fear. I figured I could figure things out. If I needed MacGyver something, the airway, do some, I'd use all these special cool tools, and you thought you were cool that you could do all that, and you want to step up and help the surgical ICU and help with the airway. And but it's also interesting that after, when other things don't go as planned or you have challenges, like those help define you. I guess there's a few things I want to say from what you said, is that so in general, like think of it as little PTSD moments. When things don't go the way, it defines your practice, the way you practice, to ward off or prevent. There are reasons in anesthesia why we're so particular, and not everyone really understands that, because you haven't seen shit hit the fan. Sorry, I just have to say it. Because when you know that if you don't do this, that there is a small chance that something like could happen, like whether it's something simple. Let's say you extubate a patient and they're going through, maybe you do a deep extubation, like you had them under gas, maybe you're transitioning with propofol, and which can kind of soften the wake up that sometimes gas anesthesia is like. Sometimes people shake, some people like clench their jaw, and especially really strong young men, like you can put an oral airway in and keep them from biting the tube when they're going through these stages. Or if you'd pulled the tube and, then they start doing it later for some reason, like you could ward off what's called negative pressure pulmonary edema. So these little things that we do are very intentional for a reason. And you find out the hard way when you don't do those things, and they end up being one of the few that you have to deal with the ramifications and the complications that could come from it. So there's a natural stress when if you just think about hypervigilance in and of itself. Like hypervigilance, you have to kind of be on your toes, so to speak, or at least be ready to deal with the stuff. And so when things go wrong, it is stressful. We may not show it as much. Some people show it more than others. Apparently, I can hide it pretty well for quite a while, unless it's really, really, really bad. And then I feel like, you feel that like kind of that adrenaline rush internally that's not so comfortable. And there was something else that you said, like just about, the acknowledgement of your department chairman or whoever that particular physician
Program
was.
director. That was a program director.
The program director. And the acknowledgement is just like anything with patients. They have a complaint or a pain or whatever it is, and just normalizing it and acknowledging it and recognizing that it is inherently stressful when you are not only just looking out for a patient if something's not going right, but when you're just learning and or your faculty's not there and you're trying to decipher, create a perspective, but it's so narrow and you can't zoom out as well. And so I think that as you get experience, you can zoom out to the big picture.
Mm-hmm.
And I find with nurses and physicians, you get really intense, like focus, and it's so focused that you can't see the forest for the trees. And so I think that, for me during that first year, I never intended to do anesthesia initially. I did general surgery for a year, and that counted as my internship. And I really, it's a long story, but I did 2 internships, not because I flunked something. It's just because I couldn't take a year off and I was waiting for a different program. And anyway, so I realized you don't really know what it's like until you're doing it yourself. And it goes to another level. We've talked about this before, when you're outside of the academic realm where you don't have anyone to fall back on. But when you go from observing, the observer, to the doer, it is a huge jump. And I still have this vision of me when I was at the VA, because that's part of where my training was. We had a catwalk between the VA and the university hospital. So we trained in different kind of patient populations. And I just remember when suddenly there's a lot of blood loss from the surgeon standpoint. Of course, these are also residents that are performing surgery with them. So some things don't go right, whether it's in an attending situation or a resident. And I just remember never having to give blood before. And I just remember, I still can see my acrobatic motion. I'm trying to like do all kinds of stuff, drawing up some drugs and then trying to squeeze the bag and like turning around and doing something else with the ventilator and then trying to deal with something for the surgeon. And I'm like by myself, like doing 4 different things. And that's why we always say we'd love to have be like an octopus and have like 8 arms. Because many times when we get in a predicament, it's not necessarily about making a decision what to do. It's having the physical capacity to actually implement all the things you need to do. And so if somebody is getting anesthesia, it is always good to have, if you have a second pair of hands that understands anesthesia, whether they are another anesthesia colleague of some sort, whether it's a nurse anesthetist or an anesthesiologist, or even some techs that have been around for ages that kind of know what's what and what to hand you and how to set it up for you. I mean, those are critical components to really, having the best to be able to handle an unexpected emergency. So someone that goes to a remote dental clinic that's doing some significant sedation, I'm not just calling out them, but anywhere remote, if you have limited sets of hands to help out with an emergency, that's pretty scary. So for us, we'd rather have other people around that we can call on, even if they're not really part of our, group or whatever in the private world. It's just good to know that someone else knows what you do, because even people in the operating room, the surgeon or, circulating nurses that are there, they don't always, their thought process, they only see what we do superficially, kind of like when you're the observer as a rotating medical student or intern, before you're in your anesthesia residency or out in practice. Like, what they see is a very limited view. So I'm always educating people on why I'm doing what I'm doing, because I always feel like that helps them help me later. So anyway, I've been going on a tangent forever, but any thoughts about that?
Oh yeah, like a ton. Like it made me think of, you're talking about limited hands and things like that. And I can't remember who they were now, which I feel really bad about. But I always appreciated when the surgeon, if the surgeon was there, like for induction, like there
Mm,
were certain surgeons that, and maybe they, I don't know, who knows the reasons why. Maybe they had a bad experience. I don't know. But they would be there for the induction. And to me, that exemplified that they cared about the case. And they were there with me and they were actually helpful.
yes.
And that was really pretty cool. Like, because then they're watching me do what I was doing in that moment in time. They were actually making sure, I think making sure that, maybe I had difficulty with the airway or something, and they could actually restyle out a different tube, like different size. People are not going to go into all the detail and stuff, but they were there. That was a
Yeah.
huge, big deal.
Yeah.
Um, and the other one is what you were saying when you talk about zooming in and zooming out, right? And this kind of reminds me about like learning in general. When you are learning something, your focus narrows down to what is happening right in front of you.
Hmm.
And that, when you are new to anesthesia, you are basically now doing these things step by step, and you're oftentimes reacting to things.
Yeah.
And ultimately, the goal of your training is to get that experience where your viewpoint now expands to the macro level or even the meta level, where you're thinking about how you think about what you're doing,
Yeah.
where now you can see multiple steps in different kind of simulations. So that being able to think, because now you're able to pre-act
Hmm.
and you are no longer reacting. And that's like the model of like, that's like great anesthesia, is to solve the problems before even anybody else becomes aware that they're a problem, because they're not a problem yet.
Yeah.
And that I think was that's sort of like the mastery process. And that was really, I just remember when you start moving into that thinking pattern, that was pretty cool. Like away from the dumb, stupid CA1 little, the 6 months in where you like, oh, this is so easy. I just do this and this. And then you need a couple disasters to occur that you really learn that no, it's not, and that's the big myth about anesthesia. I think everybody thinks they can do it because we have made it very safe, because it used to be much more dangerous, but over decades and a lot of vigilance, there's only like, I think we are literally the only specialty whose malpractice insurance has decreased,
Yeah.
because
Yeah.
we've actually made the field safer.
Yeah. And the monitors, pulse oximetry and capnography, those things are important
Oh
around
yeah,
this too.
oh yeah, and we made all that too. I mean, we were the Kevin Tremper, who was chair of University of Michigan, actually invented the pulse oximeter, or was one of the inventors. But anyway,
Very
he was
nice.
a guy too. Um, yeah, and I think that people, the human body is so remarkably resilient. I think people do have a tendency to get nonchalant and think that you could do whatever and they're going to be fine. That is not true.
Yeah.
And you brought up the out of the OR sedation, which again, if I'm remembering this correctly, it certainly was, 15 years ago. The largest increases in the anesthesia closed claims, when closed claims are malpractice claims, and the anesthesia has a database of these in a national level. When they look where these lawsuits are, and
Hmm.
what that has done for a specialty is allowed us to actually see where the profound risks are, right? I mean, it sounds horrible, but malpractice, generally something bad occurred.
Hmm.
And so that allows you to monitor those and learn from those and grow from those and hopefully improve so we don't have those again.
Right.
And the largest percentage were out of OR sedation. And I see that again, I'm not in anesthesia anymore, but
Yeah.
I see the news and everybody thinks they could administer propofol, and everybody and their mother wants to do. If you're a specialist, and I don't see this with the surgeons so much. I do see it with specialists who do procedures, who aren't necessarily surgeons and think that they can do everything and run their own sedation and they don't want anesthesia around. You need a couple, I don't want to even say that because the person who's going to pay it is the patient.
Yeah.
But they are completely oblivious to the risks, I think, in a lot of ways, because they haven't seen them, because humans are remarkably resilient. But there's a reason that you have somebody, and particularly an anesthesiologist involved, so to prevent that bad stuff from occurring. Yeah, man, you just made me think, like, out of the OR when they never remember that about anesthesia versus sedation. There's usually they made it all optimized for the proceduralist to get all their stuff. And they have the cart 14 feet away with 65 feet of extensions, increasing dead air. You can't do anything. Yeah, that's the stuff about anesthesia that really made me mad, is how we've done such a great job of making things so safe that people have forgotten how important it is. And so they just don't even think about it anymore.
Yeah. No, I think anyone that's administering a heavy sedation or even propofol thinking they could do it lightly, there is no guarantee as to how that patient's going to respond, especially if it's synergistically impacting their respiratory rate with other drugs that either they are taking orally or additionally IV, that anyone administering that should not just know, like, no, I need to grab the ambu bag or help the patient breathe. You should have legitimate experience at managing the airway. There is hands down, I mean, I can't tell you how many people have watched me do what I do day in, day out, and maybe a nurse or a physician. And the active utilization of your hands and how you open the airway to effectively breathe for them with an ambu bag is in the middle of stress. Like, you've got to be used to essentially, resuscitating somebody without stressing out. Like, yeah, you got to be able to, or at least knowing what to do and not being freaking out because you don't ever do it, but never or once every couple of years. But when I talk about general anesthesia for patients, we might give them a little relaxing medicine to go back to the room, just to kind of, and everyone swears up and down that they never see the room. It's like, you see it, you just may not remember it. But we get you in the room many times. General anesthesia for adults, we are giving an IV medication, but after we get the monitors on, you breathe a little extra oxygen. There's several reasons for that, but we give medicine through the IV. You drift off into a nap within 30 seconds to a minute. It's not like the movies where you inject someone in the neck and they immediately pass out. Like, you got to wait for circulation time, people. Like, whoever's making these movies out there, please be reasonable in how you're timing all this. So anyway, it's amazing how you have an impression on people out there in society when you create these movies that are not even practical.
When they're doing open heart surgery, when the guy's got a nasal cannula
and a little 20 gauge IV and no central line. And, anyway, so a little sarcasm here, but so you give this IV medicine. Most of the time it's an IV induction, we call it, to get you off to sleep. It's called an induction. We get you off to sleep. You sometimes temporarily don't breathe for just a few seconds, but we're airway experts. We just take over temporarily. And so we manage by helping you breathe so that we can maybe put a regular breathing tube in or some other little device that slips behind your tongue to allow you to breathe without obstructing, because we keep you so deep because you're unconscious. So you stay asleep with the breathing tube or some device, but you're breathing medicine mixed with oxygen, or we're continuously giving some IV medicine in a few, types of cases. Like colonoscopies, that's another thing we could talk about later. But anyway, so you are managing essentially controlled resuscitation for patients when you are transitioning them into general anesthesia. And so, like Kevin said earlier, it's kind of like that brink of life and death. If I didn't take over, obviously there could be a problem, but it's pretty standard for us. We take over on purpose to keep you safe. And then we put a breathing tube in or whatever we're going to do for you to keep you safe throughout the procedure, and then turn off the stuff that you were given to keep you drunk enough to be unconscious. And then you breathe it off or it wears off and, you just wake up. There's no on and off switch. That was the whole point behind this, is that, there is a transition of consciousness we take you into depending on what's needed. And then we just, it's not about waking you up. It's allowing you to wake up. It's like you just take away the drunk stuff. And some people are, I call them quicker waker uppers. Some are a little faster, younger, more spry. Sometimes that wears off faster for others. But most people wake up within, 5 to 30 minutes after stopping anesthesia, depending on what you're getting. And that's the general anesthesia world. So, and I should put a plug in. It's a free video out there on YouTube. You can find it by going to whatisanesthesia.com. I have a 19-minute long version. And if you just want to see the airway devices being put in, it's 6 minutes long. It's on that same page. And I did my own IV to myself not too long ago that you can actually see how I start an IV on myself, which is what's done to other patients. But anyway, there you go. Any comments?
No, other than we'll talk about this and people smile and nod and they still won't have a clue what we do. But
I know. But I think it's interesting just to kind of like just say how we see it,
Well, and you brought up a couple interesting things like resuscitation, like bag mask ventilation, being able to use a mask on somebody's face and then be able to use the when they blow the bag like they do in the movies. That's hard, and most people do it wrong, and and that just comes up to training, right? You see, have you ever walked into a code and there's like
they're smashing their face.
All of the oxygen is smooshing out off the sides. You're not getting anything because I can hear it.
Yeah.
They're completely obstructed. And people just, like you said, if you are going to deal with sedation, then you need to feel at least somewhat competent. And if not competent, even better is to recognize the seriousness of what that means. Yeah. Because if they're not going to be able to protect themselves, like, we always use this term sleep. Anesthesia is not anything close to sleep, because if you are sleeping, you are breathing on your own. If for some reason you get something in your throat, you're going to cough because all your natural protective things, your body is going to be naturally protecting itself. When we take that away from you, or God forbid, somebody else who doesn't know what they're doing takes that away from you, then whoever is going to be the new guardian at those gates needs to be competent. Anyway, so anesthesia is like a lot more than people know. It's amazing.
Yeah, it's an enigma and to a lot of people, and something that, I feel like part of this, I feel very committed to trying to educate or demystify a little bit of the anesthesia experience. And not that they'll fully understand it or grasp it, but I like people to understand the most basic things that will be done to them or for them. And that if there's some side effect or some little, something that's bothering them, then it makes full sense to them when they're trying to make sense of, whether it's a sore throat or, these little things here or there. But I definitely feel like, even doing, when it's possible to talk to the patient before surgery or the day of anesthesia, half of the battle is kind of demystifying a little bit and calming some of their fears and helping them realize, yes, there's always risk, but the likelihood of your situation, these are the things that are typically what happens. And this is probably what you can expect as well. I never make guarantees, but I say more than likely. And this has been my experience at this point. And so that gives some level of confidence. But I think when you show that you care and you are trying to give them an understanding, just even trying to educate and spending the time with them beforehand makes them feel like you care. Unfortunately, many times you have to demonstrate that care and get their trust like immediately before surgery in many cases. So it can be mind-boggling and stressful on an already stressful situation for surgery. So, I think that I think we should do a better job at trying to help people understand and be realistic.
Well, yeah. People everywhere universally can a little bit understand of what the anesthesiologist does. Yeah. But all right, well, I think that we could
end there.
Things I'm like, but
we'll do another episode one time.
we should definitely do it, because you brought up all sorts of things. I was like, oh yeah, what about this and this and this? But all right, Melissa, why don't you take us off?
All right,
or down or wherever.
Out, down, out like knocking out in anesthesia. So thank you all for listening to our little insights into the anesthesia world. There's so much else we didn't go into, but I appreciate you all joining us. I'm Melissa Katie, the Challenge Doctor, with my co-host, Dr. Kevin Cuccaro. And if you want to join the community at The Change Physician, you can go to thechangephysician.com, whether you're a physician or a physician ally. We'd love to see you there, or you feel free to rate, review, or comment on any of our podcast venues for The Change Physician, and we always appreciate that. And we'll look forward to seeing you on the next episode.
Take care, folks.